France, basically interested in the clinical application of imaging in lymphoma in general, but specifically in Hodgkin lymphoma. Paul Bröckelmann from Germany is a resident physician in hematology and medical oncology at the Department First of Internal Medicine and the German Hodgkin Study Group at the University Hospital in Cologne. And his research is also focused on classical Hodgkin lymphoma with the aim to improve outcomes in first line and in the relapse setting. And Carmen Martinez is Associate Professor and Senior Consultant at Hematopoietic Stem Cell Transplantation Unit in the Hematology Department at the Clinical Institute of Hematology Oncology in Hospital Clinic, University of Barcelona, Spain. Over to you, Mehdi.
Hi, thank you, Anna. So our fourth speaker in this session is going to be Dr. Wendy Osborne. She is going to debate that you don't need radiation therapy in classical Hodgkin lymphoma. Professor Osborne is a consultant hematologist at the Freeman Hospital in Newcastle in UK. She is the chair of British Society of Hematology, Lymphoma Special Interest Group, and a known authority for patients with lymphoid disorders. Our last debate of this session is going to be how best to approach patients with what we call triple Hodgkin lymphoma that has failed a checkpoint inhibitor, brentuximab vedotin, and an autologous transplant. So Professor Carmello Carlo-Stella is going to debate that the best treatment modality for these patients is an allergenic transplant. Professor Carlo-Stella is a world-known authority in lymphomas. He's a professor of hematology at the Humanitas University in Italy. He has led several translational and clinical trials and is credited for FDA and EMA approval of several gangbuster drugs for patients with lymphoid malignancy. Debating Professor Carlo-Stella is going to be Professor Sairah Ahmed. Sairah Ahmed is a hematologist, oncologist, and a lymphoma and cell therapy expert at the MD Anderson Cancer Center in Houston, Texas. She medically directs the inpatient CAR T-cell program for lymphomas at MD Anderson. So without further ado, let's jump into these 6 exciting talks back by back, and then we will look at our Q&A session.
Good morning to everyone. Before to get started, let me thank Colim organizer for this kind invitation to the first Congress on Controversies in Lymphoma. In the next 10 minutes, I will try to convince you that a definite role for brentuximab vedotin has been set, proposed, and demonstrated in advanced stage Hodgkin lymphoma. Those are my disclosures. Well, I will start with a direct comparison between ADCETRIS plus AVD versus ABVD in the first-line treatment of advanced stage Hodgkin lymphoma. For the last decade, the standard treatment as ABVD provided a high survival rate for patients with advanced classic Hodgkin lymphoma, in part due to the improved skill and efficacy of salvage treatment. Different therapeutic strategies have been proposed as frontline therapy or advanced stage Hodgkin lymphoma, ABVD-based, interim PET adapted or non-adapted, but the long-term benefit in terms of overall survival failed to show a substantial advantage over standard ABVD. On the other hand, BCOP escalated through more active of ABVD in terms of 5-year progression-free survival and overall survival showed a non-trivial long-term toxicity and mortality, being secondary MDS-AML responsible for 1/3 of the deaths from secondary cancer as major causes of death. In the phase 3 Echelon-1 study, the data analysis after 5-year follow-up supported a long-term benefit of PFS of first-line ADCETRIS plus AVD versus ABVD. Finally, an alpha-controlled pre-specified overall survival analysis for patients in the Echelon-1 study after approximately 6 years follow-up. The experimental arm turned out as the first regimen able to show an improvement in overall survival versus classical ABVD in previously untreated advanced stage Hodgkin lymphoma, with a hazard ratio for death reduced to 0.59 in the experimental arm. Briefly, you all know the backbone of Echelon-1 trial, 1,300 patients from 218 clinical sites in 21 countries all around the world were included. Stage admission was stage 3 and 4. Patients were randomly allocated in 1-to-1 ratio to standard ABVD for 6 cycles, or the same regimen in which bleomycin was replaced by brentuximab vedotin 1.2 milligram by kilo infusion, days 1 and 15 of every of the 6 cycles. The primary endpoint was modified PFS per independent review facility, defined as the first evidence of progression, death from a cause, or an end of therapy PET with read as Deauville score 3, 4, 5, followed by any subsequent anti-cancer therapy. An interim PET was also planned after the second cycles of chemotherapy, but this was a non-decisional PET, only observational. Moreover, patients scored 5 could receive an alternate therapy per physician choice, and this was not a modified PFS event. After 73 years of follow-up, the 6-year progression-free survival, according to investigator assessment, was clearly superior for the experimental versus standard arm. 6-year progression-free survival 82.3 versus 74.5. And the number of PFS events were 159 in the standard arm as compared to only 112 in the experimental arm. Here you can see the results of pre-specified analysis by subgroup and analysis significant for the factors significant for 5-year progression-free survival. And as you can see, IPS score 4 or more, stage 4, baseline B symptoms either present or absent, and extranodal sites, one extranodal site or more than one extranodal site were significant for PFS prediction. On the other hand, a non-pre-specified analysis was the one regarding the role of interim PET on the final treatment outcome. The red curves shows the two arms, the PET2 negative and PET2 positive in the experimental arm. 1,166 patients included. The black curves show the PET2 positive patient in the experimental standard arm, only 105 patients. And you can see here that despite the fact that the difference in outcome was more marked for PET2 positive patients, due to the much lower number of patients enrolled in the PET2 positive arm, the difference was more significant for PET2 negative. However, moreover, you should take into account also that patients scored 5 were excluded from the calculation. PET2 positive versus PET2 negative was a significant poor prognostic factor in all the patients. You can see here the progression-free survival of PET2 positive in the experimental and the standard arm in all the patients, in patient aged less than 60, in patient aged more than 60. In all the 3 strata, PET2 positive had a negative impact on the final treatment outcome. Sometimes later, the analysis of overall survival was presented and it was published in New England Journal of Medicine in July of this year. After a median follow-up of 73 months, the overall survival for patients included in the experimental arm was superior to that in the standard arm, in which 64 deaths were recorded as compared to 39 in the experimental arm. Again, as the results of pre-specified analysis are reported in this forest plot graph. You can see here that a minimum benefit was observed for patients aged more than 60 and for patients enrolled in Europe as compared to other regions. On the other hand, nearly all the other factors, and especially IPS 4 to 7, stage 4, extranodal site more than 1, and performance status 2 or more were significant in predicting overall survival. Which were the causes of death in Echelon 1 trial? Any cause, 64 in the standard arm versus 39 in the experimental arm. Unfortunately, we cannot dissect what is meant by Hodgkin lymphoma or complication. There was not the chance to go through to analysis case by case, but anyway, you can see how they were much more frequent in the standard arm, as well as it was the death during treatment associated with pulmonary toxicity. On the other hand, febrile neutropenia was an issue in the A+AVD arm, and 7 deaths were recorded due to this factor. What about the comparison between AVD versus interim PET adapted ABVD? Here you can see the follow-up of Echelon 1 trial after 36 months, and I adopted this analysis based on comparison to make possible a comparison with other trials in which the median follow-up was 3 years or 4. Those two trials were the Italian HD or 6 or 7 trial and the English rattle study. As you can see, the patients enrolled in the standard arm of the Echelon 1 and a negative interim PET had a 3-year progression-free survival of 87.2, which was more or less the same than what observed in the Italian HD or 6 or 7 and in the British rattle. On the other hand, if you consider patients with a positive interim PET, the outcome of those patients in the experimental arm of the Echelon 1 was superior to that recorded in the other 2 trials in which patients were addressed to BICOP escalate. In conclusion, after 73 months of follow-up, A+AVD proved superior both in terms of 5-year progression-free survival and overall survival to standard ABVD in the subgroup of pre-specified analysis, stage, extranodal site, IPS more than 4, and ECOG, as well as in the overall population. In a non-pre-specified analysis, a positive interim PET scored with the Deauville score 4 was associated with an inferior outcome than in PET2 negative in both experimental and standard arm, with a higher delta in the experimental arm. This difference was less marked in PET2 negative patients, despite a higher reduction in hazard ratio for the high number of patients included in this subgroup. Thus, therefore, PET2 interim PET maintained his predictive role also in the A+AVD treatment. The number of deaths in Echelon 1 are in line with the risk factor, but a longer follow-up is needed to clarify more precisely the reasons of Hodgkin lymphoma complication. The Echelon 1 trial results favor the use of A+AVD in all stages in all advanced stage Hodgkin lymphoma patients, or alternatively in high risk ones included. And I want to thank you, all of you, for attention. But before finishing, back to the question: should BV-AVD be the new standard care for advanced stage classical Hodgkin lymphoma? The answer is yes, but please look at the subgroups. Interim PET positive yes, both in terms of 5-year progression-free survival and 6-year overall survival. An arbor stage, yes, for both parameters. IPS equal or more than 4 for both parameters. Extranodal sites, 1 or more than 1 for both parameters. And performance status for 6-year overall survival. And I want to thank all of you for your attention.
So good day, everyone. My name is Dr. Paul Bröckelmann. I'm a physician with the German Hodgkin Study Group, and I'm happy to discuss whether or not the BV-AVD should be the new standard of care for advanced stage Hodgkin lymphoma. These are my disclosures, and besides my relationships with pharmaceutical companies, I think it's important to acknowledge that I'm basically following the guidance of the German Hodgkin Study Group in this setting. And first, I wanted to look at the first-line Hodgkin lymphoma therapy and see whether or not problems are really all solved. If looking at the CS statistics shown on the bottom, we can see that over the last decades, the death rates substantially decreased while the rate of new cases remained stable. So I think it's fair to say that we have been able to cure more of our patients, which is due to intensified multi-agent therapies in the first line, but also due to novel agents approved in the first line and relapsed setting. However, there remain unmet needs, and I think it's fair to say that this especially applies to patients with advanced stage disease, again shown by recent CS statistics, and also for older patients who have a higher mortality. So the proportion of death due to Hodgkin lymphoma is largely increased among these older patients. If we ask our patients what's their preference for a first-line treatment, and these are two surveys conducted in Europe, we can see that most patients prioritize freedom from relapse and death over side effects. And this is basically consistent across these two data sets. In advanced stage Hodgkin lymphoma, there has been the ongoing debate whether or not the first-line treatment should be the more intensive escalated BIOCOP regimen or the less intensive ABVD or AVD regimen. And there has been a network meta-analysis out there for quite a while now, which impressively shows that the overall survival indeed is more favorable with escalated BIOCOP, and especially if this is used for 6 cycles compared to ABVD, as shown by this forest plot and also by the survival curves on the right-hand side. However, there remain concerns regarding acute and late toxicities of this intensified regimen. We now know that the 5-year progression-free and overall survival with PET-guided escalated BIOCOP are excellent. And this is both true for the French HLA trial, but also for the German HD18 trials. And this especially applies to patients with interim PET2 positivity. So as you can see here on the bottom left, the curves for the PET2 negatives and PET2 positive patients virtually overlap. So these patients have very favorable outcomes despite their usually poor prognosis interim PET result if they are initially treated with BIOCOP escalated and if they continue treatment with BIOCOP escalated. On the other hand, the outcome is way more dismal if the patient initially receives ABVD and then later on is escalated to escalated BIOCOP or BIOCOP 14, as was shown in the RETHEL trial. And I think one can appreciate, while this is a cross-trial comparison, that these curves are very different from each other. So what we as a study group have been doing is trying to reduce the overall intensity of escalated BIOCOP while maintaining the excellent outcomes. And what others have been trying to do is to improve efficacy of ABVD, especially for these high-risk patients. And to this end, the ECHELON-1 trial was conducted, and this is the 3-year data published in Blood. And one can nicely see that the blue curve of brentuximab AVD is more favorable than the red curve of ABVD, and there is a significantly improved 3-year progression-free survival of 83 versus 76% with the experimental regimen. And this recently translated in an overall survival benefit. So these curves do separate over time, and the hazard ratio for death is 0.59 with a significant confidence interval. And I think it's fair to say and to acknowledge that brentuximab AVD does improve not only progression-free, but over time also overall survival. However, ABVD in this setting, as I've shown before, is not the most effective comparator, and it's not a PET-guided treatment approach. If we look at reasons for death and second cancers in the ECHELON-1 trial, we can again appreciate that these deaths observed in the ABVD group are largely due to Hodgkin's lymphoma or second cancers. And it appears that numerically, and this is taken from the recent New England publication supplement, solid tumors are similar between those two groups. However, hematologic malignancies are nearly double the time observed with ABVD, and these are the cancers that also contribute to the second cancer-associated mortality with ABVD. If we compare cancers or second cancers across the three large, most recent trials in advanced stage Hodgkin's lymphoma, we can appreciate that these seem to be in the range of 3% for the ECHELON-1 trial, but also for the HD18 trial, and seem to be a little less in the French trial where PET-guided escalated BRCOP was initially applied and then de-escalated to ABVD if the patient achieved a PET-negative response. So in summary, there appear to be lower rates with PET-guided escalated BRCOP followed by ABVD compared to either treatment with 6 cycles of BV-AVD or to more cycles of the escalated BRCOP. If we now look at general adverse events, and this is again taken from the most recent, from the initial publication of the trial in the New England Journal, we can see that more grade 3 and also serious adverse events were observed with brentuximab AVD compared to ABVD, and that these percentages, so 83 of the patients experience a grade 3 or higher event, are rather high. And this is something that's especially worrisome regarding the polyneuropathy, because this is a life quality impairing event. And as you can see here, with the most recent follow-up, there's still a significant proportion of patients that had persisting PNP of up to grade 4 at last follow-up. So this is something that is the price you pay for the higher efficacy of the brentuximab-based regimen compared to ABVD. In terms of fertility, which is also a very important aspect, especially for the younger Hodgkin lymphoma patients, we can see that the birth numerically appear a bit higher, or the pregnancies appear a bit higher with the brentuximab vedotin AVD-based versus the ABVD-based treatment. And however, this is not really adjusted for the higher number of relapses and death accounted in the ABVD arm. And we, if we further look into the supplement, we can see that there actually are no differences for the male patients between those two groups. Looking at fertility, comparing ABVD and 6 to 8 cycles of BRCOP, this is taken from a recent Nordic registry data presented at the EHA meeting. We can see that similar childbearing rates are observed for female patients, but reduced rates in males receiving BRCOP-based treatment. As was discussed during the meeting, this analysis is not yet stratified by the number of ABVD cycles received. So it could be that this is, for example, comparing 6 to 8 cycles of BRCOP to 2 to 4 cycles of ABVD. And as we all know, this is a cumulative effect. It's very important to account for the number of treatment cycles. And this, again, does not take into account in vitro fertilization rates. And the emerging data also shows that PET-guided escalated BRCOP, limiting the overall number of intensified treatment cycles to 2 to 4, appears to improve the gonadal recovery and also fertility in male patients receiving PET-guided escalated BRCOP versus 6 cycles of escalated BRCOP, as recently shown in the JCO by our French colleagues. Focusing on the high-risk group, and as I said in the beginning, the patients that are initially receiving an AVD or ABVD-based treatment and that are PET2 positive are of concern. And this is something that the ECHELON-1 trial does not really seem to overcome. As we can see on the bottom, the PET2 positive patients the PFS in the PET2 positive patients did not differ significantly, and the rates are rather low, with a 6-year PFS of 61% and 46% respectively. And just to put this into perspective, the 5-year progression-free survival in the HD18 treated PET2 positive patients is 90%, so roughly 30% higher than this observed if the upfront treatment is AVD based. Focusing on the other subgroup that is in an unmet need, so the older patients, we can see that both for patients that are older than 60 years, but also older than 45 years, there's no significant progression-free survival benefit and also no overall survival benefit with the experimental regimen. I think it's important to acknowledge that these are rather large, low subgroups, and that this was not powered to show a difference in these populations. I think the trend goes towards a benefit also for a BV-AVD based regimen. However, as we have seen, the rates of adverse events with this regimen, including febrile neutropenia and also polyneuropathy, is higher than conventional ABVD. And this is, I think, to be kept in mind if approaching an older Hodgkin lymphoma patient. So to summarize, and I know this is limited due to a cross-trial comparison, we can, I think, postulate that there's higher PFS and overall survival rates, especially for the group of PET2 positive patients, if we start with escalated BRCOP. The pregnancy rates for female patients appear comparable, and the status of male patients with modern individualized PET-guided escalated BRCOP treatment need to be determined. There are comparable second cancer rates for 6 cycles of BV-AVD compared to PET-guided escalated BRCOP, and the duration of a PET-guided escalated BRCOP approach is especially is way shorter, so that should read 24 weeks compared to 14 to 22 weeks, which also helps the patient to get over the treatment in a shorter duration. This is why our standard recommendation remains a PET-guided escalated BRCOP for patients below the age of 60, and BV-AVD, either concomitantly as done in ECHELON-1 or sequentially, as shown by Evans and his colleagues, is a very attractive option for patients above the age of 60. And I just briefly want to highlight the sequential BV-AVD regimen, which really shows nice objective and complete response rates and a very favorable progression-free survival of this subgroup in need. So to conclude my talk and also provide some perspective, I think it's important to acknowledge that one size doesn't fit all. So there is no single standard of care. And in my opinion, it would not be BV-AVD if there was a standard of care. We need to individualize our approaches based on a baseline patient and disease characteristics, their preferences, as well as the interim response, ideally measured by PET and circulating tumor DNA in conjunction. And we should treat patients upfront with an intensified treatment, for example, escalated BRCOP for now, because this appears to improve outcomes, especially in high risk or slow responding patients. However, upfront and on treatment identification of these patients who need these intensified approaches remains really challenging. So for now, as I said, the recommendation would be to perform PET-guided escalated BRCOP if the age is below 60, and either sequential or concomitant BV-AVD in patients above the age of 60. How do we move things forward as a field? That's what's going on in the United States. So the US intergroup trial comparing 6 cycles of Nivo-AVD versus BV-AVD in patients with advanced stage Hodgkin lymphoma. This is both, again, not a PET-guided treatment, and aims to improve the tolerability and efficacy of the AVD backbone. More recently, the international HD21 trial completed enrollment, and as you can see on the right-hand side, the experimental BRCAT regimen, which substitutes bleomycin by brentuximab vedotin and procarbazine by dacarbazine and prednisolone by dexamethasone. So overall provides a more tolerable and less intensive treatment regimen, was compared to escalated BRCOP, and this trial has completed recruitment, and we are eagerly awaiting first results on tolerability, but also efficacy. On the right-hand side, is the most recent long-term follow-up of the phase 2 trial for this regimen, and it shows really ongoing long-term disease control and high efficacy of the experimental BRCAT regimen. And with that, I would like to conclude. Thank you very much for your attention, and I'm very much looking forward to the discussion.
Hello, my name is Carmen Martinez. I'm a senior consultant at the hematology department in Barcelona, and thank you very much for having me today. I'll try to defend in the next minutes the role of the radiotherapy in the treatment of the early stage classical Hodgkin lymphoma patients. Hodgkin lymphoma is an increasingly curable malignancy in most adults, and modern therapy combining chemotherapy and radiotherapy results in cure in greater than 85% of early stage patients, with greater than 95% alive at 5 years. The major current goals of therapy are still to reduce the need of second-line therapy and also to reduce treatment-related toxicity, especially late adverse events. So long-term follow-up of patients treated with the combined modality therapy reveal increased risk of radiation-related toxicity, such as second malignancies, cardiac disease, and thyroid deficiency, that persist even 40 years after the initial treatment. As a result, several studies have been conducted over the years in order to reduce the number of chemotherapy cycles and also to eliminate radiation therapy. The results of these studies demonstrate continued high rates of cure, but at the risk of increased relapse rates. The translation of findings regarding late toxicities from the old retrospective analysis to current day decision-making is difficult because of major changes in radiation fields, dosing, and techniques over the last years. And also the radiotherapy late effects appear decades after the end of the treatment. So a very long follow-up is necessary to analyze the impact of these changes. Historically, radiotherapy alone was the mainstay of therapy for patients with early-stage disease. Over the years, the addition of chemotherapy to radiation therapy improved outcomes and permitted reductions in fields and dose of radio. However, late mortality from solid tumors and cardiovascular disease makes radiation therapy a less attractive option for the best risk patients who have the highest probability of cure and long-term survival. More recently, evidence that a negative PET-CT identifies patients with an excellent prognosis when treated with AVD set the stage for PET-adapted trials in which patients with a nearly complete metabolic response to short course of chemo were randomized to receive consolidative radiotherapy or not. Currently, this approach has become a standard, so I will focus the talk on the results of these trials. This slide summarizes the design of the studies that currently guide treatment in adults. In the UK RAPID trial, asymptomatic patients with non-bulky disease received 3 cycles of AVD, followed by a PET scan. Patients with a Deauville score 1 to 2 were considered PET negative and randomized to either 30 days involved field radiotherapy or no further treatment. The largest PET-adapted study, the EORTC-H10, enrolled favorable and unfavorable patients. In this slide, you can see the design of the favorable group. In the experimental arm, patients received 2 cycles of AVD, and if the interim PET was negative, 2 additional cycles of chemo were administered. In the study of the cancer and leukemia group B, all patients received 2 cycles of AVD, and those with a Deauville score 1 to 3, this is different from the other studies, complete treatment with 2 cycles of AVD with no radiotherapy. And finally, the German Hodgkin study group developed the HD16 study, in which patients with 2 cycles of AVD and involved field radiotherapy 20 grays were compared with a PET-adapted option, in which patients with a Deauville score 1 to 2 received no further treatment. This slide summarizes the results of these trials. All of them failed to show non-inferiority in PFS with PET-adapted omission of radiotherapy compared with combined modality of therapy. In the RAPID trial, patients who not receive radiotherapy had a significantly lower progression-free survival, with 94.6% in comparison with 90.8% in those treated with combined therapy. Similarly, in the H10 trial, the omission of radiotherapy was associated to a lower PFS with a hazard ratio of 15.8. And in the German trial, a difference of 7.1% in PFS was observed between radiotherapy, yes or not. None of these studies observed differences in overall survival. Regarding the group of unfavorable Hodgkin lymphoma, the H10 trial compared the addition of radiotherapy to the PET-adapted treatment, in which patients with a PET negative received a total of 6 cycles of AVD. And in the German trial, HD17, the approach is a little bit different because induction therapy is more intensive, including 2 cycles of escalated BCOP plus 2 cycles of AVD. Those patients with a PET negative, Deauville score again 1, 2, receive no further treatment. Similarly to favorable group, in the ERTC trial, non-inferiority of AVD only compared with combined modality treatment could not be demonstrated. However, the difference was a little bit lower than that observed in the favorable group. But in the German trial, using, as I mentioned before, BCOP plus AVD, no differences were observed between chemo alone and consolidation with radiotherapy. So the conclusions from these trials are the RAPID H10 and the HD16 failed to show non-inferiority in PFS with PET-adapted omission radiotherapy compared with combined modality therapy, particularly in favorable early-stage Hodgkin lymphoma. Well, we have to note that there was a lack of overall survival benefit with radiotherapy. So in young patients with a PET negative Deauville score 1 to 2, the use of 6 cycles of AVD is a reasonable alternative if we assume a 5 to 7% decrease in PFS. But we have to take into account other factors, for example, age, because a shorter course of chemo, 2 to 4 cycles of AVD plus radiotherapy, may be preferable for these patients in whom there is an increased risk of pulmonary and hematological toxicity. Regarding the unfavorable group, and according to the HD17 trial, radiotherapy can be omitted for patients that are treated with the 2+2 regime. And the author of the H10 trial also conclude that chemo-only approach using 6 cycles of AVD could be considered and should be individualized. But on the other hand, those patients with PET-positive Deauville score 4 to 5 after 2 AVD, radiotherapy should remain part of the therapeutic regime, and switching therapy to escalated BCOP plus radio or to experimental approaches are reasonable options. But what about the radiotherapy that we are using currently? We have to notice that intensity modulated radiotherapy techniques minimize the amount of total tissue receiving high doses. And in terms of volumes, the standard of care at present are involved site radiotherapy or involved nodal radiotherapy according to the International Lymphoma Radiation Oncology Group guidelines. The advent of PET has played a pivotal role, enabling the possibility to target limited fields. This minimization of treatment volumes has been accompanied by the reduction of prescription doses from 40-44 to the current 20-30 grays dose ranges. But how bad is modern therapy for long-term survival? So in this recent study, patients treated between 1999 and 2005 from the Nordic registry were evaluated. Patients were treated with 2 to 4 cycles of AVD and limited field radiotherapy. These patients were compared with the general population, and the author found no significant excess of mortality. In this other study, analyzing whether the risk of secondary breast cancer is reduced in women with Hodgkin lymphoma treated with smaller field radiation therapy in comparison with mantle field radiation therapy and chemo only. This study shows that the 20-year estimated risk of secondary breast cancer was significantly higher for the mantle field radiation, and there were no differences between the smaller field radiation and chemotherapy only. What about the cardiovascular disease? In this sub-analysis of the RAPID trial, the author predicted 30 years absolute cardiovascular risk from patients that receive PET negative, that receive involved field radiotherapy. In this analysis, for the majority of these patients, the predicted cardiovascular risks are small, so radiotherapy may provide net benefit. And the author concludes that this risk should be even lower with the most modern radiotherapy techniques. So, is there convincing evidence for the use of chemo plus radio in patients with early stage Hodgkin lymphoma? I think that the answer is yes, but we have now PET guide strategies that are the standard of care and allow us to select which patients, in fact, benefit from radiotherapy. And we have to take into account other factors for individualized therapy, such as age, sex, risk stratification, the presence of bulky disease, the level of radiotherapy exposition to organ at risk, patient's preference, of course, and if the patient is or not candidate to intensive salvage therapy in case of relapse. Of course, radiation oncologists should be part of the multidisciplinary medical team in order to take the decisions, and improvement in radiotherapy techniques may result in less late adverse events. So thank you very much for your attention.
So radiotherapy is not needed for patients with early Hodgkin lymphoma. And I'm delighted to put forward the arguments against using radiotherapy because I think it's very clear. I'm Wendy Osborne, a haematologist from Newcastle in the UK. So I think that we should go back to all remembering our Hippocratic oath, that first we should do no harm. If we look at the data, which I will be summarizing for you, it is extremely clear that we overtreat many patients to prevent just one relapse. We know from all of the data that there is no overall survival benefit with radiotherapy because those few patients who do relapse usually respond very well to second-line treatment. And radiotherapy has late effects. And in fact, the late effects that we know about are underreported because we don't have enough follow-up in our clinical trials that I'm going to talk to you about. And these late effects are even more important in Hodgkin lymphoma compared to other lymphomas because it affects younger people. So I would argue for using a PET-directed approach and reserving radiotherapy for the high-risk patients. So when we think about early Hodgkin lymphoma, we do have to think about how it's categorized just to interpret the studies. And we have favorable or so-called unfavorable, although patients hate that term. And I try and use the term intermediate rather than unfavorable. So if a patient has any of these risk factors, so slightly different between study groups, but pretty similar, then they are deemed unfavorable or intermediate. And if none of these risk factors are present, then they're favorable. So what data do we have for the favorable patients? I think that we can think mainly of these three trials. So the RAPID trial, 3 ABVDs, and if the patient is PET negative after 3, randomized to radiotherapy or not. And a similar approach in HD16, but this time randomized to the radiotherapy after only 2 ABVDs. The H10 trial, slightly more complex design, and I'll come on and speak about that. So what have we learned from RAPID? Yes, there is a small progression-free survival benefit if the patients had radiotherapy, just over 6% if you look at the per protocol analysis. But look, 90% of patients are progression-free at 3 years with chemotherapy alone. So I do want you to consider all of these extra patients in whom you are delivering this toxic treatment with late side effects, many so far unquantified. All of these patients, 90 of them outside of the box, would have benefited from chemotherapy alone and not required the radiotherapy. And remember, in RAPID, these patients were not given additional chemotherapy. So you didn't need to give them extra treatment to try and avoid them having the radiotherapy. So the other thing that we learned from RAPID was that actually the PET positive patients have an inferior outcome, which makes sense, doesn't it? We would expect that. But it's actually the Deauville-5 patients who do badly. So if you look at that 5-year PFS for the Deauville-5 patients, it's only 62%, with a reduced overall survival. Now, patients who were PET positive in RAPID did have an increase in therapy, a further ABVD and radiotherapy. But I think it's important to recognize that even with that, the Deauville-5 patients do well. So I would argue that instead of us irradiating all of these PET negative patients, the majority of whom will do very well, we should focus on treating the high risk PET positive patients and mainly, possibly, the Deauville-5s. Now, RAPID was the majority early favourable patients. There were about a third unfavourable patients, whereas in HD16, they were all favourable patients. And if you look there, a similar outcome with that addition of radiotherapy, a small PFS benefit, no OS benefit, and most people will do very well. So you are giving a lot of treatment unnecessarily. Now, in H10, patients were divided up front into favourable or unfavourable. So you can see at the top here, if a patient was favourable, they were either randomised to the standard arm of a 3+30 approach, or they were randomised to the PET-directed arm of chemotherapy alone, 4 ABVDs. In the unfavourable arm, they had a bit more chemotherapy, so either a 4+30 approach or 6 ABVDs. All PET positive patients were escalated with escalated BV-AVD and radiotherapy. So let's look at the benefits of the patients if they had the radiotherapy. So yes, there is a progression-free survival benefit, and that is more in the favourable group of 11.9% difference. But look at the outcome if patients just had chemotherapy alone. 87% of the patients still remained progression-free at 5 years. And it comes back to that argument of treating a lot of additional patients for a small PFS benefit. And I would argue this even more in the unfavourable or intermediate group, where the patients actually only had a 2.5% benefit from giving them radiotherapy. And it's often this group of patients that I worry even more about the late effects and toxicity of radiotherapy, because they may have widespread mediastinal disease. So these are the patients that we really do consider extended chemotherapy to try and avoid the toxicity of radiotherapy. Now, the PET positive patients, as I've said, are higher risk, and they were shown in this trial to benefit from escalation to 2 escalated BV-AVD and radiotherapy. So what have we learned from the early trials? We've learned about this slight reduction in PFS, but the overtreating of many other patients. We've learned that PET-guided escalation does improve PFS if the patient is PET positive, and it's these patients that are identified as the highest risk of treatment failure. So this is the image I want you all to remember. An extra 90 patients in rapid given radiotherapy that they may not have needed, maybe a fewer in H10, but not many. And the amount of patients that are needed to be treated for a small number of patients to be preventing a progression. Now, this is my 24-year-old student I treated last year. And although I am keen for you to be in favor of this notion of that we don't need radiotherapy, it's these patients I'm even more keen for you to believe that in, because for this man, the toxicity and late effects of radiotherapy will be huge. The clinical oncologists in our MDT were very clear that there would be concern about cardiac involvement, even with modern radiotherapy techniques. They were very keen for us to be avoiding radiotherapy. So what are our treatment options? So we have the HD17 approach, the so-called 2+2, where patients are given 2 escalated BV-ACOPs, 2 ABVDs, and then the PET negative patients after 4 cycles were randomized to radiotherapy or not. We have the H10, as I've shown you, the unfavorable or intermediate arm. And then we can consider treating these stage 2B or bulky patients with an advanced stage approach as there. So Rathel, dropping the bleo if IPET negative after 2, so a total of 6 ABVDs, but only 4 AVDs after the IPET if PET negative. HD18, 2 escalated BV-ACOPs, if PET negative, a total of 4, if PET positive, a total of 6, but continuing with excellent outcomes even in that PET positive arm. Or AHL 2011, 2 escalated BV-ACOPs and de-escalating to 4 ABVDs if they're PET negatives, all with excellent outcome. So HD17 was the first trial to show that if a patient is PET negative after 4, you do not lose any progression-free survival by omitting the radiotherapy. And so look at that 5-year PFS, between 95-97% in both arms in these early unfavorable or intermediate groups. So this is allowing us to try and avoid radiotherapy. About 9% of patients were PET positive at the end and did need radiotherapy. In the UK, we switched the procarbazine to dacarbazine, so we give escalated BV-ACOP DAC to try and reduce toxicity further, to try and reduce the impact on fertility. And our data are showing that we are not losing efficacy with this approach, and we are improving on toxicity. And we know from the AHL 2011 study that for patients treated with just 2 cycles of escalated BV-ACOP, the toxicity is minimal and the fertility outcome is very encouraging. So let's look at all of these trials and the outcome for patients with early intermediate Hodgkin lymphoma. Now, it is different trial populations, so we do have to be cautious of comparing these data. But let's look at the 2 on the left, HD17 and H10. 100% of patients in these arms or trials were early unfavorable or intermediate patients. Just over 40% in Rathel, a smaller number in HD18 or 2011, so they will be higher risk patients because the majority are advanced patients. But then let's compare the outcomes. So in HD17, if they are PET negative, their PFS at 5 years is 95%. Fantastic. PET positive, only a 9% risk. But still a reasonable PFS, 82% at 5 years, although there is a drop-off, but a small number of patients. So with this approach, you are avoiding radiotherapy in most patients, a small risk that they're going to be PET positive, and an excellent outcome. Now, the H10 approach is fantastic for patients that are IPET negative. If you look at that, that's only 22% were IPET positive. So the IPET negative patients, an excellent outcome of 90% if they had the 6 ABVD, so similar to RATHL, and I would tend to still drop the BLEO if I was following this approach. The problem with this approach is we have to be mindful that 22% were PET positive, and these patients, to get a good outcome, were still escalated to BV-AVD and radiotherapy. So you have to be mindful that you've got a 1 in 5 chance of the patient still requiring radiotherapy. Now, RATHL, again, great if the patient is PET negative, still a 10% inferior PFS compared to HD17. But the problem for me is the PET positive patients in RATHL. Yes, the whole cohort, yes, 60% advanced, but a 3-year PFS of only 68%. So we do need to be considering escalating patients up front if we do want to avoid radiotherapy with these early intermediate disease. Because, you know, HD18, even the PET negative patients, the PET positive patients had an 88% 3-year PFS. Now, these are going to be few patients that are PET positive that you want to treat intensely, maybe keep them on the BV-AVD if you decide to do an interim PET. But I think that we must discuss these data with our patients. So just to summarize, that we must remember that as well as the over-treating the majority of PET negative patients for our early favorable patients, for the early intermediate patients, there are many in whom the toxicity is extensive. And we need to consider which approach will allow the patient the best chance of avoiding radiotherapy while still maintaining a good PFS. So don't forget the risks of radiotherapy. Don't forget the late effects, secondary malignancies and cardiac disease in particular. And I urge you to remember your Hippocratic oath of first doing no harm. And I rest my case. Thank you.
Good morning. I am Carmello Carlo-Stella, Professor of Hematology at the Humanitas University in Milano. And first of all, I want to thank the organizers for inviting me at this very interesting meeting to discuss the issue of triple refractory classical Hodgkin lymphoma patients as potential candidate to allogeneic stem cell transplantation. Triple refractory CHL are quite rare patients. However, this is the most challenging unmet medical need in the field of refractory Hodgkin lymphoma. For this patient, allogeneic stem cell transplantation may represent a potentially curative treatment, but it requires bridging therapies to reinduce CR or PR prior to allogeneic stem cell transplantation. There are at least 2 different strategies that we can use to induce CR or PR in triple refractory CHL. The first one is represented by taking advantage of chemotherapy after CPI to get advantage of the CPI-induced chemo sensitization. Another approach would be the use of novel agents, for example, camidanlumab, and I will shortly discuss also this point. So let's start with chemo sensitization. It's since a long time it has been hypothesized and reported that patients receiving PDH inhibitors are in some way chemosensitized and they so respond better to chemotherapy. There are at least 4 papers published between 2018 and 2022 involving 150 patients or so, and reporting an overall response rate ranging from 60 to 90% and a complete remission rate from 40 to 80% in patients who receive chemotherapy after checkpoint inhibitors. And these patients, bona fide, were reported to be refractory to chemotherapy prior to checkpoint inhibitors, therapy with checkpoint inhibitors. In our series reported in 2022, we studied 28 patients who achieved a 93% overall response rate and 80% complete response rate after being chemosensitized to PD-1 inhibitors. These 28 patients were refractory for 92% of them to the last chemotherapy prior to anti-PD-1 therapy. And they had experienced as best overall response, responsiveness to PD-1 therapy, 64%, and refractoriness as 36%. However, responsiveness as best overall response was lost, and so once these patients got lost their response to checkpoint inhibitors, they were started on different chemotherapies, mainly based on gemcitabine as a part of the backbone of therapy. And as I said, 80% of these patients experienced a CR. However, we don't know about the duration of the response because by institutional guidelines, 25 out of 28 of these patients were addressed to an allo transplant, and with a median follow-up of 21 months, they had a progression-free survival not reached as median value, as well as the same as for median overall survival, which was not reached, but the 2-year PFS was 71%, and the 2-year OS was 83%, which is interesting because these patients essentially all received prior brentuximab. They all have received 64% of them had received an autologous stem cell transplantation, and finally they have also failed response to PD-1 therapy or were refractory to PD-1 therapy. So this means that these were triple refractory patients, and these are the results, however, on a very small series. Interestingly enough, chemosensitization with PD-1 inhibitors was associated with a complete disappearance of circulating tumor DNA. And in fact, 5 of these patients that could be studied by analyzing their circulating tumor DNA showed the complete disappearance of every DNA mutations in the blood after 2 cycles of VEGF. So this is an important finding of this approach. The other strategy that can be used for induce a response in triple refractory classical Hodgkin lymphoma patients is the use of novel agents. Camidallumab is an antibody drug conjugated anti-CD targeting CD25 and is conjugated with pyrrolobenzodiazepine. This agent has been used in more than 120 patients with classical Hodgkin lymphoma. These were triple refractory patients because they had failed autologous transplantation, brentuximab vedotin, and also checkpoint inhibitors. And with this agent, 70% achieved a response, with 33% of these patients achieving a complete response. So again, this is another interesting platform that can be used in triple refractory patients before addressing them to an allogeneic stem cell transplantation. Now, before getting into the results obtained in triple refractory patients with allogeneic stem cell transplantation, it's important to set the scenario of the efficacy, the outcome of allo hematopoietic stem cell transplantation in Hodgkin lymphoma prior to the appearance, the availability of checkpoint inhibitors. This is a study published by Anna Sureda in 2008. It was essentially a comparison of myeloablative versus RIC conditioning as a conditioning for stem cell transplantation. And as you can see, the non-relapse mortality ranges from 30% to 60%, and the progression-free survival ranging from 20 to 30% for myeloablative versus RIC conditioned patients is quite disappointing. The initial studies allo stem cell transplantation after CPI in Hodgkin lymphoma patients were reported between 2017 and 2021 by several groups, mainly from the Dana-Farber. And these were experience of international multi-center retrospective series, and where patients were mainly derived from the initial trial experience, phase 1, phase 2, every phase 2, with nivolumab and pembrolizumab. There were toxicity signals reported, particularly for acute GVHD, which had a cumulative incidence ranging from 20 to 28% versus an expected value of 10%. And there were also patients experiencing VOD or febrile syndrome required prolonged steroid therapy. But despite these initial warnings, the efficacy, despite in a limited number of patients and with a follow-up which ranged from 6 months to 2.5 years, the efficacy was interesting, with a PFS values ranging from 60 to 80% versus an historical value of 32%. So based on these initial results, several second generation studies have been reported by different groups, including a very large international study reported by Wright Merriman and published in Leukemia in 2021. These second generation studies pointed out a benefit of post-transplant cyclophosphamide for these patients. And in fact, the use of post-transplant cyclophosphamide was associated with an excellent values of 2-year PFS, ranging from 75 to 80%. Interesting results of graft relapse-free survival at 2 years with a 60% median. And a non-relapse mortality ranging from 4 to 13%, with a 14% of grade 3/4 acute GVHD at 6 months. So this is a much reliable and large platform of patients treated with this approach. Another important concept emerging from these studies, these second generation studies, is that remission depth is very important. And in fact, patients transplanted in CR have a 2-year PFS of 82%, whereas patients transplanted in PR have a 57% 2-year PFS. And intervening therapy is also important, but has no impact on the outcome. It's important intervening therapy, that means the therapy administered to patients who fail checkpoint inhibitors in the interval between checkpoint inhibitors and transplantation. This therapy is important because it improves the response and the deepness of response, but has no negative impact on the outcome of allografting. Now, let's go more in depth in the results reported by Wright Merriman. This was a large international effort involving several centers both in the US and in Europe. 209 patients were enrolled. The best response to PD-1 in this series was CR 39%, PR 39%. However, the disease status at Allo involved a 58% of CR in 121 patients and 32% of PR in 66% of the patients. The difference is essentially related to the intervening salvage therapy administered to 40% of this cohort, that means 100 patients. So the majority of the patients reported in this study had received and failed autologous transplantation. This was 74%. The great majority of them had received brentuximab vedotin, and they had also failed the initial response to PD-1, and that's 50%, 48% of them required an intervening therapy to improve their disease status at allografting. So we are in the setting we are discussing today of triple refractory and stem cell transplantation. And if we look at the results, we can see that the safety of the procedure is absolutely consistent, with a non-relapse mortality of 14% and a cumulative incidence of relapse of 18%. These patients overall experienced a progression-free survival of 68% at 2 years, with an overall survival at 2 years of 82%. Even more interestingly, the graft and relapse-free survival was 46%. And this is particularly evident and important in the context of PTCI. In fact, patients receiving PTCI experienced a 58 or 57%, so a similar graft relapse-free survival, irrespective of their donor, with patients who did not receive PTCI having a 30%, only 30% 2-year graft relapse-free survival. This is a very this is something that changed the status of this approach in Hodgkin lymphoma as compared to all previous allografting studies, and has obviously an impact also on progression-free survival, which is substantially, even if not significantly increased in both APLO and non-APLO patients, 70 and 77% respectively, versus a 60% in no-APLO, no PTCI patients. And again, a benefit, a trend of benefit is also evident on overall survival, with 83% and 91% of patients receiving an APLO or non-APLO, respectively, patients experiencing this high value of survival, versus an 80% in non-APLO, no PTCI patients. So in conclusions, allogeneic stem cell transplantation can be performed safely in triple refractory classical Hodgkin lymphoma patients. The optimal transplant strategy for these patients involves the use of PTCI, and so allo stem cell transplantation should be considered for triple refractory CL-HL patients. Thank you for your attention.
Thank you so much for inviting me to speak today. My name is Sairah Ahmed, and I'm an associate professor at MD Anderson Cancer Center. And I will be talking today about treatment strategies for refractory Hodgkin lymphoma. These are my disclosures. Triple refractory classical Hodgkin lymphoma, defined as patients who have had disease that progresses through brentuximab vedotin, checkpoint inhibitors, and autologous transplant, are the patients that I'll be talking about today. So we know that Hodgkin lymphoma is a very curable disease, and in fact, more than 90% of patients with early stage disease have curative intent treatment and achieve cure for Hodgkin lymphoma. In fact, even in advanced stage and high IPI patients, there's still a 60 to 75% cure rate. However, 20 to 30% of patients will either be refractory to initial therapy or relapse following frontline therapy. And treatment option for those patients after disease progression is generally an autologous stem cell transplant, including treatments with brentuximab vedotin and checkpoint inhibitors. However, after those treatment options have been utilized, there are very limited further therapeutic and, in fact, curative options. So generally, the approach to relapsed or refractory Hodgkin lymphoma is defining whether patients are eligible for autologous transplant or not, and then choosing salvage chemotherapy, chemoimmunotherapy, with the intent of getting to an autologous transplant. In fact, after disease relapse post-autologous transplant, there are few options, including allogeneic transplant, clinical trials, potentially novel agents. However, for many patients, it may be going back to the drawing board in terms of immunotherapy, radiation, and then palliative chemotherapy with hospice. Over the last several years, we've seen the introduction of immunotherapy from the relapse setting into the frontline setting. And more patients are being exposed to these agents earlier in their disease status. As you can see, recently presented data for frontline brentuximab vedotin plus AVD has shown an overall survival benefit. And this is going to be the new standard for advanced stage Hodgkin lymphoma, barring comorbidities. And again, so that data in terms of response rates for patients to these agents was all on checkpoint and BV naive patients. So we're kind of coming to a point where we don't know what these response rates are going to be going forward. So what do we do after an autologous transplant has failed? What's next? Do we choose novel agents? Is CAR T-cell therapy an option? Or do we try to get to an allogeneic transplant? When we talk about novel agents, there are a lot of them out there. And generally, when you see a long list, it means that there's not much that does what you want it to do. And so in this graph or this table, we've actually looked at what are the overall response rates and the complete response rates for some of these new novel agents. And I'd like to kind of point out, I'm not going to go through the entire list, but in these trials, a large number of patients have actually had prior autologous transplant. And in fact, exposure to other novel immunotherapy agents such as BV and checkpoint inhibitors. And we can see that at the best, we have a complete response rate in very small numbers at 62%, with at worst for everolimus, 8% complete response rate. In patients who have been exposed to checkpoint inhibitors, if we try to expose them to, again, in addition to another agent, as Brian et al. Demonstrated, ruxolitinib plus nivolumab has an overall response rate of 48% and a complete response rate of 24%. I think one of the agents that many people were very kind of excited about was camizestrant, with an overall response rate of 73%, a complete response rate of 40% in a highly refractory patient population. However, this agent has its own toxicity and side effects, which have led to holds in the clinical trials. So let's talk a little bit about CAR T-cell therapy for Hodgkin lymphoma. So patients who have relapsed after autologous transplant have poor outcomes with a 5-year overall survival of about 30%. Autologous CD30 CAR T has demonstrated efficacy in patients in relapsed and refractory CD30 positive lymphomas in a number of trials. And we'll highlight the Rely 30 trial and then the Chariot trial. And again, the CD30 CAR T is very similar to the CD19 CAR Ts, and this is with a CD28 co-stim. So we're going to look at this phase 1/2 trial of autologous CD30 CAR T in relapsed and refractory CD30 expressing lymphomas. This analysis basically includes classical Hodgkin lymphoma. As you can see, 56 patients underwent procurement, and of those, 42 actually had infusion of cells. This particular trial was conducted at 2 different sites, reported by Ramos et al. In the JCO in 2020. There were 25 patients at one institution and 17 in another. At UNC, where the 25 patients were treated, there were 2 different arms of lymphodepletion, with a few patients receiving bendamustine alone, while the vast majority received bendamustine and fludarabine. At Baylor, there were patients who received only fludarabine and Cytoxan lymphodepletion. Of note, the flubenda arm had the highest dose level at dose level 3, while the remaining 2 arms had multiple dose levels. What I would like to highlight, though, is that this was a very refractory patient population, although young. The median number of prior lines of therapy was 7, with a range of 2 to 23. The vast majority of these patients had received both brentuximab vedotin and checkpoint inhibitors. And in fact, if you look at all patients, 76% had received a prior autologous transplant, and 24% had had a prior allogeneic transplant. The responses by the type of lymphodepletion are something that we need to explore a little bit, because this has driven the way that these trials have been conducted moving forward. So the bendamustine alone arm had an overall response rate of 0, and that arm was subsequently dropped, whereas the bendaflu arm and the Cy/Flu arm both had much higher overall response rates. The winner essentially was flubenda, with a overall response rate of 80% and a complete response rate of 73%, in comparison to 65 and 47% respectively with flu/cy. And as you can see in the graph below, there is an actual plateau. And I think that with a lot of the Other CD30 CAR T constructs that have been reported in the past, this plateau is not quite so clean. The median follow-up was 533 days with a 1-year progression-free survival of 36% and a 1-year overall survival of 94%. The most common toxicities that were grade 3 or higher were hematologic. And the safety profile is pretty impressive for CAR T-cell therapy. Cytokine release syndrome in 10 patients, all of which were grade 1, and there was no neurotoxicity observed. Based on the foundation of that prior trial, the Chariot trial was subsequently conducted. And it's a phase 2 multi-center single-arm study of autologous CD30 CAR T, specifically in relapsed and refractory Hodgkin lymphoma. This particular trial has 2 arms, a pilot trial and then a pivotal trial. And the pilot has 12 patients with the pivotal, which is ongoing, having 82 patients. It was open to patients 12 to 75 years old, and the disease failure had to be inclusive of 3 lines of therapy, which included brentuximab vedotin and a checkpoint inhibitor. Patients may have had a prior autologous or allogeneic stem cell transplant. And again, based on the prior data, the lymphodepletion chemotherapy was fludarabine and bendamustine. The primary endpoints for the pilot were safety and overall response rate, and the secondary endpoints of the pilot were duration of response, PFS, OS, as well as quality of life. The pivotal trial has not yet been reported on. So there were 17 patients who were screened and 15 enrolled in the pilot over 4 sites. Again, these patients were very heavily pretreated prior to receiving CAR T-cell therapy. It was a fairly young patient population with a median age of 34 years and very good performance status. Looking at the clinical variables, the median range of prior lines was 6 with a range of 3 to 18. 85% had received prior brentuximab vedotin and 92% a prior checkpoint inhibitor, 85% having a prior autologous or allogeneic transplant. The adverse events were, again, mostly hematologic. There was 1 cytokine release syndrome that was grade 1. And interestingly, there was reports of a maculopapular rash that was fairly easy to treat and resolved either spontaneously or with topical steroids. Similar to the prior study that was done by Ramos et al., the overall response rate was quite high at 71% with a complete response rate of 57%. And if we look at that swimmer's plot, you can see that the ongoing complete responses are actually pretty significant. And there are patients who did receive a second infusion of cells as per protocol. I think the other thing to note is the year of diagnosis. The vast majority of these patients have had Hodgkin lymphoma for quite a few years prior to coming to CAR T-cell therapy. And that may be associated also with their responses. I think a more indolent type of Hodgkin lymphoma likely has a better phenotype and propensity for response. Natalie Grover has published on CD30-directed CAR T-cell therapies co-expressing CCR4 in CD30 positive lymphoma. And the thought process behind this is that CCR4 may improve tumor homing as well as anti-lymphoma activity in comparison to CD30 CAR Ts that do not have expression of CCR4. Again, this is a very small phase 1 study. However, in the 16 patients treated at multiple dose levels, there were both patients with classical Hodgkin lymphoma as well as T-cell lymphoma. And the classical Hodgkin lymphoma patients did extremely well with 10 complete responses and 3 partial responses for 100% overall response rate. And so I think that, certainly there is room to improve in terms of efficacy of CD30 CAR T. So where does allogeneic transplant fit into the treatment of Hodgkin lymphoma? Certainly we know that it is a curative intent treatment. However, it's only for a very select patient population. And I think what we need to keep in mind is that efficacy is dependent on chemosensitivity. And these are two older studies that have been published looking at the differences in overall survival and progression-free survival in patients who actually had allogeneic transplant with chemosensitive disease versus chemo-resistant disease. And you really don't need the p-values to look at these graphs, as you can tell that, you know, chemosensitivity is key in terms of efficacy. And while I don't think anybody would argue that allogeneic transplant is still a curative option, and there have been great strides in terms of decreasing toxicity and non-relapse mortality, we know that we still battle chronic GVHD and the non-relapse mortality that goes along with allogeneic transplant for these patients. While the overall survivals can be above the 50% range, we still have a significant patient population that relapses post-allogeneic transplant after surviving a very kind of aggressive treatment that potentially has a very large impact on quality of life. So for those of you who have small children, you may recognize the CoComelon "Are We There Yet" song. So are we there yet? Can we actually look at CAR T-cell therapy as an alternative to allogeneic transplant? Can we talk about them in the same breath? And I think that when we look at the parameters that helped us define treatment for patients, there are a lot of data out here that we can make decisions about. So if we talk about toxicity, I think that CAR T-cell therapy has a much better toxicity profile in comparison to allogeneic transplant. Non-relapse mortality is basically non-existent with CD30 CAR T. You don't have the level of high-grade CRS or neurotoxicity seen in CD19 autologous CAR T-cell therapy. Time is a huge issue for patients who get an allogeneic transplant. They have to be near a transplant center for approximately 100 days, whereas for CAR T-cell therapy, it is primarily done outpatient for CD30 CAR T, and the time commitment is about 4 weeks. Logistics, I think, is pretty much equivalent between the two. In terms of the way in which we have to collect CAR T-cell therapy, manufacture, and then reinfuse. And for allogeneic transplant, being able to coordinate the donor and recipient and get patients ready for a transplant. Donor, again, you know, given the advent of haploidentical transplant, we have a much bigger pool of donors. And so I think this is pretty much equivalent between the two. I think that at this point, allogeneic transplant wins for durability of response. The kind of median follow-up time for CD30 CAR T-cell therapy is short. And while you do have a plateau, I think that the relapse rate still is in favor of allogeneic transplant. And I think the other part is accessibility. You know, you can receive a allogeneic transplant for Hodgkin lymphoma anywhere in the world. There are multiple transplant centers that allow patients access, whereas CD30 CAR T-cell therapy at this point is only available on clinical trial. And there are many more patients than slots available on those clinical trials. Thank you for your kind attention, and I would be happy to take any questions.
So welcome back, everybody, to this third session, Q&A section. First of all, I really would like to thank all the speakers for the excellent presentations, for giving their opinion on the topic, and I hope that we have a great discussion right now. So I'm going to moderate the first debate. So basically, BV-AVD, yes or no, by Andrea and by Paul. So I have some questions here from the audience. The first one going to Dr. Gallamini. So you mentioned about the interim PET post-hoc analysis in the Echelon-1 prospective clinical trial with double 5 cases that were excluded. So can you comment a little bit on that, Andrea?
Yeah. Can you hear me?
Yes, perfect.
Perfect. So I was involved from the beginning in this big debate on how to use interim PET in the Echelon-1 international trial. And this also includes the issue of so-called modified PFS, which was also another debated issue. So score 5 were allowed to exit from the study, and this was not censored as an event by upon analyzing the data in the old analysis we had got. So I have to say that thanks, lucky for us, there was an equivalent number of score 5 in experimental and in the standard arm. So this did not affect the overall outcome of the trial, but as a matter of fact, are a little bit methodological hurdle to compare the data with different treatment than A plus AVD. The second issue, which was even more important, is that so-called concept of modified PFS, which means that if patients had an end of therapy PET scored 4 or 5, but didn't get any second line treatment, this was not censored as an event. On the other hand, if the patient had showed death during treatment or follow-up or progression during treatment or follow-up, whatever was the results of end of therapy PET, this was censored as an event. But more important, if the patient had a second line treatment with an end of therapy PET scored 3, 4, or 5, this was considered an event. But if you consider the data upon in the independent review facility as compared to what was deemed by the local investigator, out of 32 modified PFS events, the independent review facility decided that only 6 accounted for a true event. And this probably could explain the knot you can see in the curves exactly after 6 months from the beginning of treatment.
So thank you very much, Andrea. I think that your answer was very, very clear. So let's move to Paul. We have here a question on ABVD easiness to be accessed across the globe, and of course, let's say the more complicated supportive measures that are associated to BCOP escalated. And I really would like you to comment on that.
Yeah, thank you very much for this very important question. And this is what I also tried to highlight in my talk, that I think that not one size fits all, especially in advanced stage Hodgkin lymphoma, because you have to take into account the individual treatment preferences of a given patient, their age, and also the circumstances they are treated in. Because as we know, the supportive measures are very different across the world, as is the access to targeted drugs such as brentuximab vedotin. And just to comment on BCOP maybe, because it's considered more toxic than ABVD, for example. And we usually administer this as an outpatient regimen by close outpatient monitoring. However, we have the facilities at hand to take care of a patient that, for example, develops a febrile neutropenia or other more severe complications. And I'm fully aware that this might not be the case for everyone treating Hodgkin lymphoma patients. And regarding BV-AVD, I largely see a hurdle towards access to the targeted drug, because this is something that is not only for Hodgkin lymphoma, but for many entities, a very big hurdle bringing these targeted drugs to the majority of people living on our planet, because we know that the access usually is limited to Europe maybe and North America. And tackling these access hurdles, not only for brentuximab, but other targeted drugs, is something that we need to work on as a scientific community, I think.
Thank you very much, Paul. I think that I fully agree with you. So the resources around the globe are not exactly the same. And of course, for BCOP escalated, that's one thing. And also for the access to BV. So the third question that we have here in the chat, maybe both of you can eventually comment on that. So as we know, overall survival is the highest level of evidence, so that one would like to see. And it's true that, let's say, in some of the cases, we see benefits in terms of progression-free survival, but second-line treatment strategies are so good that overall survival is not being seen as a difference. So could both of you comment on what represents a benefit in overall survival in BV-AVD? So initially we didn't see any difference. And in fact, I was not quite sure that we were going to see a difference at the end of the day in overall survival, but we have information now that this is the case. So maybe you can comment a little bit on that. Andrea, go ahead.
Yes. Thank you for the question. This is really a big issue, and it has been debated several times. And as Dr. Bröckelmann showed in his slide, the causes of death were lumped together for Hodgkin lymphoma and complication of Hodgkin lymphoma. And it was not that easy to dissect the relationship between complication and Hodgkin, first point. Second, there is an unexpected very high number of hematologic neoplasms in the ABVD treated group, which was not found in other prospective clinical trial dealing with ABVD, standard ABVD. So this is an important issue. And the third issue, which has not been unraveled in echelon 1, is the huge difference among different geographic areas about both PFS and OS. So just to be the devil advocate, I would say that in Europe, we didn't find such a big advantage. Okay, that's my comment.
Thank you, Andrea. Paul, what would you like to add to Andrea's comment?
I think these are three very important comments, and I thank you for this really thoughtful analysis of the echelon 1 data. I think it's great to see that there is an overall survival advantage with the targeted drug, and that's something that definitely improves compared to ABVD. So if I would have to treat a patient I wouldn't consider fit for escalated BCOP, and I had access to brentuximab vedotin, I would revert to this regimen because it appears to be more effective, tolerability is manageable, and it ultimately translates into an overall survival benefit. I was also struck by the high number of second hematologic cancers in the ABVD treatment group. This is even higher than what we observe with intensively treated BCOP patients, and that's something that's puzzling me a bit. And I'm also wondering whether any geographic regions might be influencing this. And as I also tried to mention in my talk, however, if you want to achieve a very prolonged PFS, ideally a cure, then comparing ABVD to ABVD might not be the ideal comparison because there is a more effective regimen out there. And I think if you use escalated BCOP in a thoughtful way, ideally stratified, for example, by interim PET, as done by our French colleagues in the AHL 2011 trial, and limit the exposure to 2 cycles, for example, this is something that I find very intriguing, and the data is compelling also in terms of feasibility and fertility, as also mentioned by Wendy Osborne in her talk on radiotherapy. And this upfront intensive chemotherapy seems to enable a decreased toxicity down the road while maintaining high cure rates. And for example, in the setting of intermediate stage Hodgkin lymphoma, allows us to omit radiotherapy. And I fully agree on this with Wendy Osborne that the upfront intensive chemotherapy in these patients is more beneficial than later large field radiotherapy. And to that extent, I think the overall survival benefit is great to see for our patients if they would have received ABVD. However, I think escalated BCOP in a PET-adapted way is still our preferred standard of care in these patients.
Thank you very much, both of you. I think that for the sake of time, we should move to the second debate. So Mehdi, the floor is yours.
Thanks, Anna. So I think Dr. Martinez and Dr. Osborne, absolutely beautiful both talks. So I don't think so we have any specific questions to the early stage talk with role of radiation in the chat. So I'm gonna just start the first question, and I think this is specifically for Dr. Martinez, since you were defending the role of radiation therapy in early stage classical Hodgkin. I'm curious, in your practice, are there any specific presentations or any specific populations where you tend to sway away from a combined modality approach? I'm thinking about a very young Hodgkin patient, maybe where the limited stage disease in the subpectoral area, where no matter how good the radiation technique is, the breast tissue is going to get radiation. So how do you approach these patients?
Although I defended the radiotherapy position, I might recognize that I'm agree more with Dr. Osborne. And in my own practice, we tend to administer 4 to 5 cycles of BV-AVD for young patients and avoid radiotherapy. And if we have some doubt regarding the PET2 results, we also check these results with the nuclear medicine doctors and also with the radiotherapist in order to take a decision and to see if the normal organs or areas that are going to receive the radiotherapy, so we feel safe with the decision of radiotherapy. On the other hand, for example, for patients older than 16, 70 years, sometimes we prefer to use short course of chemotherapy, for example, 2 cycles for early stage with no adverse risk factors, and to combine with the radiotherapy because these patients maybe they cannot have more toxicity, hematological toxicity, lung toxicity from the AVD, and we prefer to do short course of chemo to add radiotherapy.
Thank you, and I believe Dr. Gallamini has a question.
Yes, I have a question for Dr. Osborne, which is a question, a comment at the same time. So you showed quite elegantly that in the German HD17 trial, people treated with intensive treatment, 2 escalated VICO plus 2 ABVD, fares very, very well without any consolidation radiotherapy. And this brings me to make a comment in general on the end of therapy PET scan in early stage Hodgkin lymphoma, which has been quite elegantly studied in the German HD17 trial, but in early favorable patient, this has not been yet explored. And we are at the beginning of our experience in early favorable Hodgkin lymphoma in the rafting trial, showing that end of therapy PET-CT in early favorable Hodgkin lymphoma could very well drive radiation therapy if needed, followed by immune checkpoint inhibitor. So this is our experience. So, probably this is explained by the fact that the predictive value of interim PET in advanced stage Hodgkin lymphoma is quite high, while in early favorable Hodgkin lymphoma, probably the association of interim and end of therapy PET-CT could drive very well the need for few cases which needs addition of something else.
Excuse me. Yes, and I think that that's a good point. And like Dr. Martinez, I was obviously arguing in favor of avoiding radiotherapy, whereas my own clinical view is more balanced than that, because I think that there are situations where we should be including radiotherapy for our patients. I think we also understand that at present our responses in terms of a simple PET positive or PET negative, it isn't binary. And I showed that in the RAPIDS data, showing that the Deauville 5 patients had a significantly worse outcome compared to Deauville 4. Yeah, and I think that we're also seeing that in the AHL 2011 data, where they used 140% of liver, so a bit like a Deauville score of 4.5 as positive, allowing de-escalation at less than 140% of liver, even though they were Doble 4. So I think you're exactly right that we need to make sure that we really understand what a true positive PET is. And my make sure that our clinical research are able to compare across trials, because it does make it difficult if people are having different cutoffs, as well as doing the interim PET or end of treatment PET at different times.
So very thoughtful note. And Dr. Osborne, I'm curious, the question is a little beyond what you talked about, but these bulky patients who happen to have limited stage disease, what's your practice if at the end of the treatment, a patient has a nice, clean, negative PET scan, maybe make it real simple, the Duvel score is 1 or 2. Are you routinely radiating these patients or not?
So we don't, and I think that we've seen, well, lots of data now that consolidating bulk in PET negative patients isn't, especially in escalated BV-ACOP upfront, is not required. So our practice for advanced stage, whether we use an HD18 approach, which I have to say we use a lot now because of all the data that's been discussed this morning, but even if we've used a RAFL approach, we tend not to use consolidation to bulk if their end of treatment is negative. I think when we use an HD17 approach, this is the group of patients, as I said, that I do worry about, because we really want to avoid radiotherapy. We know there's a 1 in 10 chance that they'll be PET positive after that 2 BV-ACOPs, and we use BV-ACOP DAC. We've replaced the procarbazine with dacarbazine, and 2 ABVDs. There are a few patients in whom I do an interim PET after 2, because if I'm really wanting to avoid radiotherapy, if that IPET2 is positive, it gives us that option of keeping them on an HD18 approach. And it weighs up that risk of toxicity of chemotherapy versus that toxicity and risk of radiotherapy. Because remember, in the HD17 trial, the IPET or the end of treatment PET was after 4 cycles. There wasn't an IPET included in that trial. But as standard, we don't consolidate routinely bulk, provided the patient has achieved PET negativity.
I think it's a very sound argument, and thank you both, Dr. Martinez and Dr. Osborne. So we are switching gear towards the last talk of the session. So the triple refractory Hodgkin's, I think both, I'm sure Anna and I will have questions, but there is an audience question for Dr. Carlo-Stella. And the question is, in patients who have failed a checkpoint inhibitor, which chemotherapy regimens were generally employed? And I believe the question is referred to the allo study after checkpoint inhibitors. So Carmello, it's sort of a broad question, interested in your thoughts, maybe your experience about which chemotherapy regimens tend to work off trial after a checkpoint inhibitor failure.
In the study we published with the international one, the study with the 200 patients, there was a huge group of patients who received an intervening chemotherapy. And if I remember correctly, 100 patients were received this intervening chemotherapy, but the regimens were something around 40. So there was a huge dissemination. In our own experience, we have always been using gemcitabine containing regimens. So gemcitabine is a fixed drug, and then we can build up around with a combination with oxaliplatinum or with bendamustine, etc. And we have always observed, even with gemcitabine as single agent, we have observed a very good partial remission or complete remission. So essentially now we stick to the gemcitabine based regimens.
So Carmello, I want to ask you a question, because you elaborate quite a lot on the APLO, in the paper by Bröckelmann, this question of APLO, cyclopost, non-APLO, non-cyclopost. So which element do you think that makes a difference in the result of allogeneic stem cell transplantation? The haplo donor, the cyclopost that we are eventually using in the haplo setting, or what do you think?
The cyclopost seems to be the most relevant part. Since we got the data from the published analysis, we have always continued to use cyclophosphamide post-transplant in all types of, irrespective of the donor, whether not haplo, familiar, HLA identical, or unrelated. So, and this is always working. So it seems that the most relevant point, rather than the donor, is the use of cyclopost, which has substantially reduced the toxicity and also improved the graft incidence and severity.
And Sairah, so moving on to CD30-directed CARs in Hodgkin's, I think you show compelling evidence that both between the initial Chapel Hill and Baylor experience and then the Chariot trial onwards, it looks like patients who happen to get to a CR, that group appears to be doing really well. I'm curious, your patients who are achieving a partial remission after CD30-directed CARs, who haven't converted that partial remission to a CR even with a repeated infusion,
and then do convert to a CR, similar to the CD19 data, CD19 CAR T data, but these are very small numbers. I think before we have really enough data to say that that's a true phenomenon, it's going to require larger numbers. You know, again, these patients are very highly pretreated when they come to us. And so, you know, getting CAR T on a clinical trial is a very sub-select patient population. And so once, you know, these patients have received a CD30 CAR, there are certainly some of them who, when they achieve a CR, we send them to allogeneic transplant because we have nothing left if they do have disease progression afterwards. In terms of what do we do after a PR, it's really then just trying to find something else that potentially could work. We happen to have another trial at our center, which is AFM plus NK cell by Iago Nieto, which is a NK cell, umbilical cord NK cell loaded with a bispecific, CD30 bispecific. And so between him and I, we definitely have gone back and forth with patients, and if they you know, attain a CR with either of our protocols and have not had an allogeneic transplant, then that's the next step. And in fact, he's done second allogeneic transplants in a couple of these folks.
Sairah, may I ask you one question? Mm-hmm. Or two very short questions indeed. The first one is, where do you position at this stage the CAR T, in which stage of disease? For which type of patient?
So I think given the safety profile, it certainly can move closer to kind of the frontline setting. And in fact, there is a trial that is open now for CD30 CAR T in the second line setting in combination with nivolumab. It's accruing. I think the main question is going to be that plateau. And how durable is the response for how many patients? And I think the other issue is accessibility. You know, as we talked about accessibility for novel agents, right now CAR T cell therapy is much, much more kind of limited, both because of the product manufacturer as well as patients being able to get to a center that can do it. As we have seen with CD19 CAR T cell therapy, even though it is now a commercial product, it is still extremely limited in terms of being able to get patients to that procedure. So I think, you know, there's a scientific background and the data behind its efficacy, but overall, at the end of the day, it's going to be, can we actually get patients to this particular procedure?
Yeah, the accessibility seems to be really the problem. In Italy, we have been promised since 2 years to receive, or to have the possibility to start a trial with CAR T cells for Hodgkin, but this has never been the gaze. So that's one point, and the other is the duration. Now, the other point was, have you any experience with a bispecific for Hodgkin lymphoma? Because there is something around with CD30 and CD3. Have you ever used this drug?
So I have heard about it. I have not yet seen it, nor do I have any personal experience. But from what I hear, either the end of this year or beginning of next year, the trial should open.
Okay, thank you.
Okay, so I think that we couldn't have made it better. So we are absolutely on time. So I'm going to close the session. Thank you very much.